spinous processes that extend down the back that also can help you enumerate or count the vertebra. And then, as I've indicated, there are some upper limb scapular structures that also are present in the back. We'll talk about those in more detail as we continue our discussion of the upper limb later. You can again see the iliac crest here. And I think a lot of these structures, again, the processes, the spinous processes, and then the features. For example, this is the scapular process here that we'll talk about, scapular spine that is prominent along the back. C7 is the first of those major processes to create a prominence there. Some individuals rarely will have a larger T1 process than C7, but for most of us, the vertebra prominens, the prominent vertebra at C7 is the definitive landmark. Of course, we talked about the curvatures. Make sure you can identify the kyphoses and lordoses of the back, the natural kyphoses and lordoses. I mentioned the supracrystal plane, so this is a fancy word, and in this context, supra means above. The crystal, in this instance, refers to the crest. So we're talking about the iliac crest. So the supracrystal plane is that plane that is just superior to the iliac crest, and you can see the little line here that approximates the location of that. And we can also see in this individual the alterations in the conformation of the surface anatomy that accompany those posterior, superior iliac spines. So between this point and these two landmarks, that gives you a pretty good indication of where the underlying bony structures are. And once again, you'll use this clinically for administration of epidurals, or in some cases even for a spinal tap. They're just showing you the surface musculature here. So we've talked about the trapezius up here. We can see the sort of triangular shape of the trapezius. The back muscles we haven't talked about yet, but we're going to find that in our simplistic representation, we're going to differentiate intrinsic from extrinsic back muscles. The erector spinae, which you see here, are the primary group of intrinsic back muscles, and they sort of run up and down the entire length of the back. So those are the primary muscular structures. Now, in this slide, there is a classification, or really an enumeration of the various types of joints in the back. And I want you to think about these. There are the joints of the vertebral bodies, and by that we're talking about the joints primarily between the bodies and the intervertebral discs. There are the joints of the vertebral arches. For the most part, these are the joints between the articular facets of adjacent vertebrae. There are the craniovertebral joints, for example, that between the cranium and the atlas. The costovertebral joints, what are they? Yeah, between the vertebra and the ribs. And then we talked about that normally relatively immotile sacroiliac joint, but when it does become motile, it can become problematic. Most of these joints are synovial, but remember those IV joints. The joints between the IV disc and the vertebra, we classify those as symphyses. And we'll talk more about that again. That's very important, understanding the nature of pain that we talked about, the source of pain in the back. And then be able to define, of course, all of these movements with respect to the back. Later, as I've indicated, we'll differentiate the intrinsic and the extrinsic muscles of the back. Most of these motions, then, are achieved by intrinsic muscles of the back. That is to say, muscles that extend up and down the back, up and down the various processes, and to a lesser extent the ribs, that enable you to articulate the spinal column, extension, flexion, lateral movement, rotation, circumduction, and so on.
Can you distinguish from your rotation and circumduction of the vertebral column?
I could when I was a young man. You know, when I was in the first grade, I won a twisting contest. This is rotation. Excuse, somebody picked me up off the floor, but this would be circumduction. This is the typical Friday night. I when I circumduct myself back to the shelter. So we've talked about most vertebrae having 6 joints. We talked about the 2 symphyses on IV disc on either side. So that's all we mean by the symphysis. We'll look at that in more detail in just a moment. And then the 4 synovial joints, usually, with the exception of the thoracics, there are 2 articular processes above and 2 articular processes below. And remember, we had a special fancy word for those. What type of joints were those? It's always fun to say. Makes your day because it's so much fun to say. Zygapophyseal. Yeah, zygapophyseal. Exactly. All right, let's talk a little bit about these intervertebral discs because they are the sort of the weak component, the weak link in this chain of structures that makes up the vertebral column. Remember, about 25% of the overall length of the column is attributable to these intervertebral discs. You will often see them described as both collagenous and cartilaginous. Both are true. The intervertebral disc consists primarily, at least the perimeter, consists primarily of fibrocartilage, including at least 2 different types of collagen. So either term would be correct. The intervertebral disc itself consists of this outer rim, again the fibrocartilage rim called the annulus fibrosus, the fibrous ring. And then at the center of the disc is this more gelatinous, semi-liquid nucleus pulposus, the pulpy center, like a Tootsie Roll pop. And in fact, this region in the center here is intended to absorb much of the load. You might imagine, you might think of the IV disc, imagine how it would handle loads if it were just another bone, if it were just a little disc of bone. All right. You have much more limited movement. If you try to shift the weight, there'd be dramatic loading of the disc anteriorly and then posteriorly. Eventually, it's likely that bone would shatter from the changing displacement, changing load placed upon it. Well, the design, if you will, of the IV disc is intended to sort of uniformly distribute the load of the upper body equatorially around the perimeter, sort of projecting the load in this direction transversely along the annulus fibrosus. And as you see it doing its thing there, you can see, for example, severe compression here. How many of you are into sit-ups? You do sit-ups? I think you'd be hard. I should have put that on my little quiz that Evan disagreed with me about. Because sit-ups, I defy you to find a responsible trainer. I don't know if I should say trainer because I'm not sure there are editorial comment here. But a responsible physiologist, a person, let's say an orthopedist specializing in the back, that would recommend sit-ups for this reason. Because you need to appreciate that mostly cartilage. So what do you know about the physiology of cartilage? Yeah, it's not a lot of, we're going to talk a little bit about the blood supply, but this isn't extensively vascularized, largely avascular, and it's not going to recover very readily from any type of structural damage that it may receive. What type of structural damage may it receive? Well, again, sit-ups, cumulative damage over time. It's not going to heal, not going to repair itself very easily from that. When I used to go into gyms before my back crises, you'd see the 17 or 18-year-old fellow walk up to the rack and just pick up as darn much weight as he could and then grin the whole time. And of course, you can imagine what's happening to the vertebra over time as that's repeated on a day-to-day basis.
That's lateral flexion, though, so it'd be the wrong crunches, right?
I'm sorry?
Lateral flexing, it'd be the wrong crunching for abs, right?
Well, you're saying, so you're saying this is lateral? Okay, lateral flexion, yeah, but the principle would be the same. Can you think of any reason that this would not be true for? If you have the ability to do that laterally, all sorts of even more things going wrong then. So I just want you to think about this and maybe think about well, we've had several students over the years. Some I don't know if they're still here that have had very severe back problems, both in the nursing program and the PA program, and it's sort of like it. We have in our society, our culture, this notion of hormesis, what is it called, the hornet philosophy. Anybody familiar with that? It's sort of embedded in the American spirit, the frontier spirit, the idea that adversity is a good thing. Adversity builds character. Stress makes you stronger. But if you go out in the sunlight every day, it may give you a little vitamin D, but it's going to have some adverse consequences over time. Likewise, the more stress, you can be as hormic as you want to. Madonna has an essay on hormic, so I'll tell you where that comes from. But I think it's sort of embedded in our culture. You can stress your back under the premise that you're strengthening yourself, that you're building, you're bulking up, and so on. But eventually, it's going to catch up with you. It almost always does, statistically. So be careful, I guess, is my point. By the way, with respect to the spelling, you see this misspelled all the time. In fact, I probably have misspelled this in the slides. Number one. And number two, we're going to see this name again, because as we have found out, a lot of these structures, the names turn up again and again to refer to different parts of the body. But notice there's one in here. Annulus with two N's refers more to the year, annulus in year. Here, the annulus implies circular or ring type structure. So as we pointed out, the entire IV disc is relatively avascular. It progressively deteriorates with age. Several things happen. Rather interesting one. Remember our discussion of glycosaminoglycans and proteoglycans? This interior tissue especially is filled with that, and as we age, that capacity for hydration, which those molecules afford, tends to diminish. So the whole thing becomes a little more brittle and less capable of distributing the load. Again, this is progressive ossification. On the one hand, the vertebra, as we age, sort of lose their density, bone density, through osteoporosis, and the vertebra sort of progressively calcify, become more brittle for a variety of reasons. So the two together do not speak well for the ability of this structure to handle the weight that it's asked to handle. Now, we're going to come back to a discussion of these supportive connective tissues, but notice that there's a band of ligamentous tissue that's sort of holding the IV disc into place relative to the vertebra. In fact, there's a whole support system in here. We have longitudinal ligaments on either end, both the anterior and posterior side. In fact, all of this is really draped in a sheath of connective tissue, which, though helpful in maintaining the integrity of the structure, may present complications if you need to access the neural structures within or behind it. I know you don't have this slide, but what I just was looking for something to sort of explain the problem of vascularizing the intervertebral disc. Right? And quite frankly, it's not well understood. Just keep in mind that this is an avascular structure. And what do you know about what's covering the surface of the intervertebral discs? Do you have any memory of that? It's what? Yeah, different portions of the intervertebral disc are covered with hyaline cartilage, so they're not going to be extensively vascularized either, at least not at the surface. Despite that, you often will see drawings or illustrations such as this. And of course, what this is implying is that there are small reticulating little capillary vessels at the surface of the vertebra that are responsible for providing diffusive nourishment to the vertebra, because that's the only way they're going to acquire it. I don't know that there's a lot of histological support for these drawings. You can see they're always drawings. They're never histological micrographs.
Here's an intervertebral disc. The disc is a massive pad of fibrous cartilage that's firmly attached to the vertebral body about circumference. If we cut through the disc and look at it from above, we see that it's made of concentric layers of material. The disc consists of an outer ring of tough fibrocartilage called the annulus fibrosus and a soft center of almost liquid material called the nucleus pulposus. The disc is solid enough to transmit the weight of the body, and it's flexible enough to permit movement between the vertebrae. The side of the intervertebral disc forms the anterior margin of the intervertebral foramen, through which the spinal nerve emerges.
Now, again, as you look at that, I just want you to be thinking about cogitating on what on earth, how is the best way to access structures in that foramen now that you see them, now that you see the whole assembly further invested with connective tissue. There's a little brief treatment on degenerative disc disease.
Degenerative disc disease, or DDD, occurs in many people as part of the normal aging process. It's sometimes referred to as arthritis of the back. The condition results from changes in the compressible spinal discs, which act as shock-absorbing cushions between the vertebrae. With age, the discs can lose fluid, making them less flexible and more compressed, or they can develop tiny tears in the outer layer, which can cause pain by themselves, or allow the jelly-like inner layer to bulge, causing pressure on the spinal cord and/or nerves. The most common symptom of DDD is deep aching lower back pain that can radiate to the top of the thighs. Pain in the morning is usually described as stiffness in the lower back. The condition can occur anywhere along the spine, but is most common in the neck and lower back regions. The resulting neck or lower back pain is usually made worse by certain activities or prolonged sitting and standing. There may be bouts of severe pain lasting from a few days to several months before returning to a milder long-term chronic pain. Many people don't realize they have disc degeneration because it frequently causes no pain at all. The cause of DDD is typically the normal wear and tear that occurs in the discs as a person ages. However, it can occasionally be caused by trauma or repetitive lifting. The affected disc becomes thinner and loses its cushioning ability. These changes affect the way the vertebrae in the spine move, and bone spurs can result, as well as bulging or disc leakage, all of which can cause pain when they contact the spinal nerves. Smoking, obesity, heavy lifting, and hereditary factors also lead to advanced degeneration. DDD causes lower back pain in most people at some point in their lives. Symptoms usually resolve on their own. Occasionally, medications and non-operative treatments are needed. Surgery is performed for those whose symptoms do not improve.
I think the figure now is that before the age of 40, almost a quarter of individuals suffer from some type of radiologically evident damage to the vertebra, or the spinal column. So then it just, the numbers increase dramatically thereafter. Now, he talked about herniation. So what's a herniation? How would you describe a herniation in this context? Yeah, so there would be a compromised integrity of the annulus fibrosus, and as it becomes weaker, that nucleus pulposus then bulges and then proceeds to emerge from the perimeter, the confines of that annulus. And so this is just a quick little demonstration of how you might address that therapeutically. I don't think there's any sound here. So there we go. So you see the herniation, and what is the nature of the problem here? Notice where the herniation is. It's not onto the cord itself. Where is it? Yeah, it's on one of those nerves. And remember, that's what I want you to be thinking about, because, of course, in the lumbar region there is no cord. We'd only have the caudate echina, and again, I want you to be reflecting upon the source of the pain. Of course, those are action potentials. We all know how white they can get. So I'm going to treat it now. what did they do there?
Eraser?
They removed a portion of the vertebra to gain access to, remember what this is? What's this?
The bulging disc.
Yeah, that's the herniation. And what's that?
Nerve.
Yeah, all right, so I just want to make sure, because it goes faster, it's blinding fast, these therapies these days, they're just done like that. And you pull it out, you wash it off, and you sew it up, and there you go. That's all there is to it. Yeah, now, so obviously that was a simplification intended to illustrate a principle. Now, at the end, before we, as we conclude our discussion at the back, we're actually going to look at we're actually going to look at that surgery and then compare it to our. But I just want to make sure you have a sense of these structures. And part of what we need to do now is talk about the connective tissue that also overlies these vertebra. And again, this area right in here, which we're focusing on, it seems to be the source of all the problems. Now, those zygapophyseal joints, which are the joints, those synovial joints between the adjacent facets, as the clinicians say, they have synovial fluid, they have a synovial capsule. There's the external ligamentous capsule. In fact, that is called the joint capsule, and it just consists of nothing more than connective tissue. And sometimes they may introduce nowadays they put all kinds of things in. They'll put Brunswick's fuse, they'll put in steroids, they'll put in the enriched plasma we talked about before. They have various mixtures, adjuvants to facilitate the function of the synovial fluid. There are all kinds of things that might help a painful zygapophyseal joint. But remember, the contour, the relationship of these joints differ from one region of the column to the next. In the cervical region, they sort of sloped, down. There was sort of an oblique angle. In the thoracic region, they were more or less vertical. The superior and inferior almost met along a vertical axis. And then the same is true in the lumbar, except in the lumbar region. Recall there's very little opportunity for movement there. They tend to be so interlocking that there's much less capacity for rotation, flexion, and so on. So let's look at these ligaments. I do want you to be familiar with these because these play such an important role in the structural stability of the spinal column. So you can see anteriorly there's going to be a long ligament that covers the entire length of the body. It's called the anterior longitudinal ligament. In reality, it's not a band like this. It sort of forms a little fascial sheath around most of the perimeter, the anterior perimeter of the bodies and the intervertebral discs. And then on the other side of the bodies, there is a posterior longitudinal ligament. So be sure you understand that those longitudinal ligaments bind the bodies of the vertebra and the intervertebral discs. Now, these pictures are a little bit difficult to parse, but I would ask that you spend some time with these so that you can identify all of the little ligaments that we're going to be talking about. So, let's focus on the upper left one here initially. So you can see the anterior longitudinal ligament here. That's the anterior longitudinal ligament. Back here, that little thing right there, that's the posterior longitudinal ligament. And then, of course, running through here would be the spinal cord. So posterior to the cord is this long, this drapery, this very thick yellowish ligament called the ligamentum flavum. Ligamentum flavum, which just means yellow ligament.
Is that ligament one long thing that goes all the way down the cord, or are they just in sections as you traverse each vertebra?
It's one very, very thick belt of these ligaments that we've talked about thus far. It's by far the most robust. Moreover, look at the relationship here. Before I answer your question completely, let me come down here. Let me see if I can find the best illustration here. Notice that over here in this illustration, let's move to the one below that. We have what are called interspinous ligaments. Those are the interspinous ligaments there. These are the ligaments that sort of extend between the adjacent spinous processes. And that in your essential anatomy, they're calling all of this the interspinous. But technically, at the end out here, the very tip, and in fact, in the essential anatomy, you actually see the histological distinction. That's called the supraspinous. So the supraspinous is posterior or superficial to the interspinous ligaments. And then notice over here, there's a similar, although much more, much smaller sort of ligament between the transverse processes called the intertransverse ligament. But let's look at the one up here at the top right now, because I want to point out something with respect to the ligament inflatum. So here is our interspinous ligament here. And notice what it does. It just sort of bifurcates to become what? The ligament inflatum. So that's a very, I guess again, the term I would use is robust binding structure. Now it certainly varies in thickness and in appearance in one region or from one region to another. But I guess the point I would make is that your job as a PA in trying to address herniations and pain issues in that intervertebral foramen, especially if it's in the lumbar region, but how do you know we're in the lumbar region here? We're looking at the cauda equina there. You're going to have to traverse, one way or another, you're going to have to traverse that ligament inflatum. If you go in from the back, probably if you go in from the side. Is that clear? Because it effectively encapsulates or protects what we're going to call the lumbar cistern a little later. Yeah.
My question is only because of an essential anatomy 5, the ligament inflatum looks rather different.
Yeah.
In the cervical region, it shows that they're just kind of curved and they're separate
Well,
between each vertebra.
Correct. Now, as you move into we're looking at the lumbar region here. In fact, a number of the ligaments change their conformation as you move toward the head. The posterior longitudinal ligament changes entirely. For example, it becomes a much thicker structure towards the neck. But certainly in this region, this is quite substantial. All right, so notice superiorly as we get up into the neck that the interspinous ligament emerges into this very long band, almost alien-looking thing, called the nuchal ligament. And the function of the nuchal ligament is to restrain and support movement of the head, especially in the anterior and posterior direction, flexion and extension. Now, there are a couple of more of these that are more evident in the, and I actually had the essential anatomy. We can explore this, and you can tell me what we're talking about here. But in the thoracic region, we have several of these structures. We have, for example, these costotransverse ligaments, and we have them there, and there. So those are costotransverse ligaments that you would find only in the thoracic region. Excuse me, as I have trouble pointing in the right direction. And then the other thing I wanted you to pay attention to and to be familiar with, notice where the head of the rib adjoins the vertebra. The binding ligament there is called a radiate ligament, radiating all the way around the joint. So again, the ligament muci, the buccal ligament. So sometimes there are developmental abnormalities associated with a variety of genetic conditions. Sometimes this is associated with a deficiency of a certain collagen, genes that code for collagens that show up developmentally. developmentally or embryologically in the ligamentum bucci. Down syndrome, for example, would be a case in point. So I don't think there's anything new. I just want to point out, so again, if we're going to approach, we need to gain access to the, we're going to try to find, deal with the herniation of the disc. Where are we, by the way? What region of the column? Yeah. So we've got a number of problems to deal with here. We're probably going to have to do some removal of bone here, substantial removal of bone in this region. May not be necessary in the lumbar region. And then what is that yellow in there? Yeah, the ligamentum flavum. So that's going to have to be dealt with as well. Yeah, a lot of structures in the neck that complicate this business. So again, supraspinous ligament here, intertransverse and cotransverse over here. You can sort of see the intertransverse there, the costotransverse along those planes. Remember in our discussion of the vertebra, the vertebral arch consists of pedicles and the lamina. So the lamina is the portion of the arch that includes the transverse processes and the spinous processes. So accessing the cord from this region would involve what is called a laminectomy. So that basically, to some degree or another, you're probably going to have to excise a portion of the bone, depending upon the objective. And there are all kinds of less invasive procedures now. And this is where we're headed. We want to somehow gain access to one of these regions in here. And so now you hopefully have some idea of what must be dealt with. Of course, where are we now? We're in the lumbar region, and you may be able to sneak through right in here, right? Just need to get into that. If there's a herniation of the disc into this region in here, then it may be possible, you may not have to perform any sort of laminectomy. You may be able to sneak in right through there and do your business. But remember, this is not cord here. It's called the echina. We're going to call that sometimes called the fecal shell or the lumbar cistern. Contains called a echina. Now in this illustration, don't be confused. What they've done is they performed the laminectomy and they flipped the lamina around. So make sure you appreciate that what we're looking up here in the top right is this, or we'll call this number 2, has been chopped off of number 1 here, and then it's just been reflected and inverted. So you're looking at the ligamentum flavum there. Question I might ask you on the test is put various ligaments in order. I might ask you what is deep or what is superficial, and make sure you know the sequence, anterior to posterior and posterior to anterior.
The vertebrae are also held together by ligaments. Some of these go from vertebra to vertebra, some run the length of the spine. Starting at the back, we'll look at the ligaments which hold the spinous processes together, the interspinous and supraspinous ligaments. Then we'll look at the ligament that holds the laminae together, the ligamentum flavum. Then we'll look at the 2 ligaments which help to hold the bodies together, anterior and posterior longitudinal ligaments. First, the interspinous ligaments. Here they are. They run from the lower edge of one spinous process to the upper edge of the next one. Now we'll add the supraspinous ligament to the picture.
Here it is.
The supraspinous ligament merges with the interspinous ligaments. It runs the whole length of the vertebral column, connecting the tips of the spinous processes. The supraspinous ligament serves as a midline attachment for some important muscles, as we'll see later. These ligaments help to limit flexion of the spine. The structure, or structures that chiefly limit flexion of the vertebral column, is the series of short ligaments that hold the laminae together, which are known collectively as the ligamentum flavum. The ligamentum flavum lies on the front of the laminae. To see it, we'll cut through the pedicles of all the vertebrae along this line. and look at the laminae from the inside. Here's the ligamentum flavum. It goes from one lamina to the next, all the way down the spine. Here, where it's been cut through, we can see how thick it is. The ligamentum flavum is made of yellowish fibroelastic tissue, hence its name, which means yellow ligament. Next, we'll look at the two ligaments which hold the vertebral bodies together, the anterior and posterior longitudinal ligaments. The anterior is the stronger of the two. Here it is. The anterior longitudinal ligament covers the front and sides of the vertebral bodies. It runs the whole length of the vertebral column. We'll cut through it along this line to see it better. The anterior longitudinal ligament is thick and strong. It's attached to the upper and lower edges of each vertebral body. It limits extension of the spine. In extension, the tightness of the anterior longitudinal ligament helps to prevent backward and forward movement of the vertebral bodies relative to each other. The posterior longitudinal ligament runs along the back of the vertebral bodies. To see it, we'll divide the pedicles along this line again and look at the bodies by themselves. Here's the posterior longitudinal ligament. It's narrow where it overlies each body, and it widens out to cover the back of each disc. The posterior longitudinal ligament helps in a small way to limit flexion of the.
So if you were asked, the spinal cord lies between which two ligaments, two sets of ligaments?
Flavium and posterior.
Not the cord. The cord lies, I think I heard somebody say, the cord lies between the flavum and the posterior. All right, so make sure you keep all, as I say, know the basic anatomy there. All right, we want to talk a little bit about the innervation and blood supply to these structures. What we're looking at here, of course, we're down in the lumbar region again. We can see the caudate kind, and we can see the emerging root and the spinal nerve. And then there are some somatic processes. We won't be too concerned about these, but I do want you to note that there are immediate somatic processes that innervate, that provide somatic motor innervation and sensory innervation in the region of the vertebra. And you can see muscular branch and cutaneous branch, and that's their primary function. We won't, as I say, worry too much about the details of this. Rather, I'm more focused upon the clinical aspect of pain. Once again, I want you to think about how pain originates and what might be going on. Remember, again, just as a simple anatomy, there is no intervertebral disc between the atlas and the axis. They have to rotate. There's no. And Ackland, in the video that you looked at, talked about the cruciate ligament. You can see the cruciate ligament there made up of the transverse and the band components. Evan was asking about the posterior longitudinal. Superiorly, it becomes this tectorial membrane, which is much thicker up in this region. And then finally, up here where the head attaches to the neck, remember the very strong and powerful, but deep to the cruciate alar ligaments. So we looked at those before as well. So what we're looking at here is the blood supply to the vertebra. And the first thing to keep in mind is that, as you see in the illustration, the vertebra are, the bone is living, thriving tissue, and it requires a rather extensive blood supply, and that's what we're looking at here. But I want to make sure you understand the general organization of this system. So we have the aorta generally descending on the left side somewhat. And then depending upon the region, we're going to have emanating or sprouting from the aorta what are called regional or segmental arteries. And by that, all we mean is that in the neck, they're going to be called cervical or vertebral. In the lumbar region, they're going to be called lumbar arteries, as we see here. In the pelvis, iliolumbar, and some other terms as well. What are they called in the thoracic region? intercostal. So we'll talk about those later, but I just want to make sure that what you're looking at here, and this is the example of the lumbar, but this would generally apply to all of those other regions. When we talk about segmental or regional arteries, I'm using both terms interchangeably, and you'll see both in the literature. So these are our regional arteries here, one going on one side of the vertebra, one going on the other. It's just that in this case, it happens to be lumbar. All right, so what you'll notice is that at all levels, the body of the vertebra is perfused directly by the regional artery through what are called equatorial branches. And that's chiefly for the outer portion, the outer rim of the body. And then here the terminology, I'm going to defer our discussion of this terminology to a little later, but what I would have you pay attention to is that the vertebral canal is also heavily perfused, and it's branches of the arteries in the vertebral canal that perfuse what's called the centrum of the vertebra. And you can see them reticulating and branching there. So there's plenty of blood making its way to the body of the vertebra. And as I say, we're going to, unfortunately for you, in the second hour, we'll go over this in more detail. And we'll need to know all these various arteries. In terms of the venous drainage of the vertebra, the system is far more complex anatomically, but by virtue of its complexity, we're just going to boil it down to a few general ideas. We're going to argue that there is an anterior region, a posterior region, and then this region of the vertebral canal. Each of those regions has associated with it a venous plexus. We've talked about plexuses with respect to the nervous system, but this fine reticulation of veins that you see draining the bone, the vertebra, is also a plexus. So here's the posterior plexus, and if you look at the next slide, you get some sense of how complex this is. This would be portions of the posterior plexus here. The anterior plexus drains the body, the vertebral body. And then all of that blood empties in, and they go by a variety of names, these vertebral veins, sinuses, or plexuses. I don't care which term you use, but in general, what we're saying is the drainage is to the center into these large conduits, veins, sinuses, or plexuses. I don't really care which term you use. The only specific anatomical or the vein that I want you to know is this large reticulating drainage vein from the body called the basivertebral vein. I'm supposed to say basivertebral, but I always say basivertebral because it sounds haughty and pretentious to say basivertebral. But I'm told that's the correct pronunciation. So with that, let's take a break and we'll come back and talk a little bit